So, good evening. This is going to be a overview of my paper regarding accessibility and affordability for diabetic care in low-income communities. This kind of hits home for me because my dad died in 1994, like 2 days after, well, the day after my 11th birthday, from complications with diabetes. So this is kind of a personal topic, so to say, for me. Imagine being a nurse, being laid off, and having to find your way to make your insulin or any of your medications last longer than the prescribed dosing factors in order to, be able to live. For years, you've counseled patients on the importance of taking prescribed medications as ordered by their treating physician. Now you sit at home alone, feeling a little bit under the weather, while you battle internally on whether or not you can last another day or another meal without even having to take any of your meds. This rings true for a 47-year-old nurse from Ohio named Megan Carter. Megan Carter died on Christmas night from complications from her diabetes and a lack of insulin in care. Growing up in the inner city, I have watched firsthand how accessibility and affordability to proper diabetic care has had a negative impact. Living on the south side of Chicago as a kid and watching my father struggle with receiving care at a local hospital each time he had to be hospitalized with what we considered sugar issues, he came back home in worse shape than when he went in. The other issue I realized later on in life is that he complained of not being able to get an appointment with his physician at times, waiting almost 45 to 60 days out. Because our family was considered low income but not having enough to receive public assistance, but making more than enough to receive public assistance, affording regular doctor visits was not always something that we could do, which is really what many families face nowadays, not only like growing up in Chicago, but also I found out while growing up in Hawaii that is another big burden is affordability and accessibility to health care. In order for my dad to receive care, he often relied on the emergency room visits as a form of follow-up care. And that's something that we've seen in many patients in the healthcare community, that when they can't have proper continuity of care, that they oftentimes use urgent care centers and emergency room visits as their follow-up care. Policy to begin to change how we can structure diabetic care can be more affordable in low-income communities will need to be a great importance and priority as we move into improved and more efficient healthcare services. Diabetes epidemic proportions. The problem with increasing healthcare costs is the effect that it affects many patient populations, but most importantly, the effect it has us on low-income communities are at disappropriate rates. In a 2017 study by the CDC, the numbers of Americans living with diabetes were over 100 million people. That is up from in 2015, where there were only 30 million Americans, which is still a high number, living with diabetes or complications from diabetes. People from low-income households have an increased risk of death due to not only having an issue with access to continuous care and preventative care, but also have comorbidities that further complicate their disease processes. The rise in new diabetic cases are encroaching epidemic numbers. If this was any other disease, there would be an outcry to improve access and affordability to care. Many low-income patients became low-income once the housing market crashed and many jobs and homes were lost in 2008. The rising cost of living expenses also left many with the debate of whether to pay a bill, eat, or pay for things important such as insulin. While there may not be a magical quick fix to mediate the problems, there are ways that with proper education, access to health care, and community health involvement, the number of diabetic deaths in low-income communities can begin to decrease. These options may include access to care for clinics for preventative care, care teams to help manage patient compliance to treatment, and education on nutrition and other resources available to the community for diabetic management. With the background and significance of this issue, the issue is the accessibility and affordability of healthcare for diabetes. The affordable and accessible healthcare for diabetes has become an issue for the healthcare community. With a 70 million diabetic population increase between 2015 and 2017, one has to question what is really the issue here. One of them is not having affordable care and access for diabetic management not only creates a problem for the patient and the community, but for healthcare organizations as a whole. So between 2003 and 2014, there were a 59% patient increase of those admitted in healthcare facilities and healthcare organizations with a primary admitting diagnosis of diabetic ketoacidosis, which means they were having a diabetic crisis. Reduced healthcare organizations and available clinics were one of the issues faced in making were faced with including accessible preventative care and follow-up for patients who have diabetes, and it made it quite difficult. So if you couple the reduction of affordable care and access to healthcare facilities, we could conclude that there is also a reduction in education and diabetic care to these patients. Healthcare accessibility has been a great issue, honestly, since the 1990s. In the 2003 book entitled Code Green, Money-Driven Hospitals and the Dismantling of Nursing, which was written by Dana Beth Weinberg, she discusses the impact of hospital closures and mergers not only on the staff, but on the patients and the community in which they serve. As healthcare reimbursements began to change and local communities began to see community hospitals that were once a pillar of healthcare and have provided access and affordable care, they are now being either dismantled, merged, or closed altogether. While at the end of the day, a healthcare organization is a business, as we all agree to, it brings the question whether or not affordable and accessible healthcare is a right or a privilege. If you couple the decreasing access to affordable healthcare and the exponential diabetic rates growth, you have conditions as of what we can see with that happening with my dad or even Megan Carter. The impact that this has on the community is that the age range of those admitted with a primary diagnosis of diabetic ketoacidosis are between the ages of 18 to 44. As we all know, the age group between 18 and 44 are our working class age group. So many of them are college students working part-time jobs, full-time jobs, taking care of families, helping families. So this is really where a lot of this diabetic ketoacidosis and this diabetic crisis is really affecting the community and population. As the numbers trend towards an increase of diabetic ketoacidosis among this age group, the number of those reporting not working to health-related issues were up by 4.4 percentage points. This means that the difficulty of replacing or accommodating employees who will need to miss work due to the diabetes or diabetic ketoacidosis diagnosis can take a toll not only on the patient himself, but the company's employee numbers and budgeting for retaining staff as well. Healthcare organizations are also impacted by the patients presenting with diabetic ketoacidosis because of due to a lack of resources and access to care. Some of the political factors or factors contributing to this will be as we all know, the implementation of the ACA, or what is affectionately known as Obamacare, is that while it opened up access to patients to receive health care and took away exclusions for those presenting with diagnosis or chronic illnesses, it also had its issues where because it was left up to the states to individually implement the ACA, a lot of patients somehow got dropped in the process. But the good thing was, because diabetes is a pre-existing diagnosis, it was now able to be covered under most major health plans. Some of the social and economic factors that we see is that, unfortunately, in low-income communities, there is a social stigmatism of participating in welfare and public assistance programs, which prevents families from seeking assistance, even if or even understanding that the benefits that are allowed to them. So this has a big impact or effect on those diabetics that are living in low-income communities. The other issue is the political factor that we have to look into this. Treating complications from diabetes cost the U.S. over $327 billion, and that was in 2017. That's up from $247 billion in 2012. Some of the things that we could tackle to improve this would be legislation. We started with the ACA, but what else can we do to improve access to care? Um, 7 out of 10 ER doctors claim that they lack the resources to deal with the increases of the number of patients that are now being seen because they get covered by insurance. So some of the issues, for example, at my job that we're doing is that we're starting to not only train regular physicians, but nurse practitioners and physician assistants also to help with the increase or the influx of patients that we have. Some of the recommendations that I thought of would be having care managers available for diabetic patients. This would be established at the point of care for patients presenting to the emergency room with diabetic complications, and the care manager would then assist the patient to through the process, which would include reminding them of upcoming appointments, prescription refills, and educating them on the various community services such as support groups. The care manager will also serve as a mediator between the patient and the primary care physician if there are any changes, hospitalizations, or concerns with obtaining refills. This will also encompass improving organizational wellness programs as well as community health programs, which will be vital in maintaining and establishing an increase of community confidence and community involvement in the treatment and management of diabetes. So overall, affordable and accessibility to diabetic care is going to take not only the patient but us in the healthcare community and the surrounding community as well.